Hi, my name is Thomas Edrich. I'm a cardiothoracic anesthesiologist and intensivist at Brigham and Women's Hospital. Today we will demonstrate performance of echocardiography, first on a simulator, then on a live volunteer. We're going to show you 5 basic two-dimensional images that are necessary for hemodynamic assessment. These are images that were described in the article called Focused Assessed Transthoracic Echo, which was published in the European Journal of Anesthesiology in 2004. This simulator consists of a probe and dummy 1 to 5 megahertz phased array cardiac probe. A small bump on the side of the probe marks the so-called index mark of the probe. This corresponds to the small marker on the top right-hand side of the screen. The first view we'll demonstrate is the peristernal long axis view. Place the probe approximately in the 3rd or 4th intercostal space, just lateral to the sternum. The index mark should be pointed towards the right shoulder of the patient. Maneuver the probe by sliding and tilting until you obtain the appropriate image. In this peristernal long axis view, you should see the right ventricular outflow tract at the top, the intraventricular septum, underneath that the left ventricle. The valves in view are the aortic valve and the mitral valve. Next to the mitral valve, the left atrium. At the bottom left hand, you see the descending thoracic aorta. The small circular structure at the rim of the left atrium and left ventricle is the coronary sinus. The next view is the peristernal short axis view. Rotate the probe about 90 degrees clockwise to obtain the peristernal short axis view. The index mark should point towards the patient's left flank or left shoulder. You're going to have to slide and tilt the probe to obtain the appropriate image. Now, in the peristernal short axis view, you should see a round structure. That's the left ventricle. You should see papillary muscles on the sides of this round structure, the anterolateral and the posterior medial papillary muscle. You should not see the mitral valve opening and closing itself, but rather just the papillary muscles as they're about to join the wall. This is the mid-papillary view of the left ventricle. Next to the left ventricle, you see the right ventricle. The next view is the apical 4-chamber view. Place the probe at the apex of the heart, where you feel the maximum cardiac impulse, normally just underneath the nipple, with the index mark pointed towards the patient's left flank. We're seeing a longitudinal view, the apical 4-chamber view. Be careful to place the probe at the apex, otherwise you will cause the ventricles to appear foreshortened. Now they're foreshortened. As I slide the probe further into the flank, the ventricles become longer and they are no longer foreshortened. In this apical 4-chamber view, you see the left ventricle on the right side, the right ventricle, the left atrium, the right atrium. The valves are the mitral valve and the tricuspid valve. Our next view is the subcostal 4-chamber view. Press the probe gently but firmly into the subxiphoid region with the probe pointing towards the left shoulder of the patient. You're going to be making use of the acoustic window through the left liver lobe to image into the heart. Slide and tilt the probe until you see 4 chambers beating. In this subcostal 4-chamber view, we see the right ventricle at the top, the left ventricle, the right atrium and the left atrium. The valves, once again, are mitral and tricuspid. At the top of the screen, we see a portion of the left liver lobe, which allows us to look through. Artifacts in this position can include bowel gas, which would prevent us from visualizing. Our last view is the subcostal inferior vena cava view. Place the probe again in the subxiphoid region. You'll be looking through the left liver lobe. Find a long vessel and visualize its transition into the right atrium. If you can visualize the transition, then you know this is the IVC entering the right atrium of the heart. One source of error here is if you were to tilt the probe too far to the left, you could visualize the descending aorta instead. But obviously, if you visualize the structure entering the right atrium, you can safely assume this is the inferior vena cava. In the subcostal inferior vena cava view, you should see the inferior vena cava behind the liver. This is the left liver lobe. The inferior vena cava collapses for every heartbeat slightly, and it can also show respiratory variation. You see the inferior vena cava entering a large structure called the right atrium. Now we repeat the echo exam on the healthy volunteer. We have the 1 to 5 megahertz phased array probe with the index mark. For the first view, the peristernal long axis view, we place the probe in approximately the third intercostal space with the index mark pointed towards the patient's right shoulder. We slide and tilt until we have a view of the heart in the long axis. In this view, we should be able to see at the top of the screen the right ventricular outflow tract. Below that, the left ventricle. The valves are mitral valve and aortic valve. The left atrium is visible. Looking somewhat deeper, we can see the descending thoracic aorta. For the peristernal short axis view, we rotate the probe approximately 90 degrees in position, so the index mark is pointed towards the patient's left flank, and we tilt and slide the probe until we obtain a round view of the left ventricle. Ideally, you visualize only the papillary muscles and not the mitral valve in this view. In this view, we see the left ventricle contracting nicely. We see the posteromedial and anterolateral papillary muscles. We see the right ventricle. We see a hyperechoic line representing the pericardium posterior to the left ventricle. Now we demonstrate the apical four-chamber view. Place the probe at the apex of the heart. This is normally just inferior to the nipple, with the index mark pointed towards the patient's left side. We've positioned the patient on his left side. That allows us a better view into the heart, since the heart moves forward in apposition with the thoracic wall, with less likelihood of lung interposition. Once again, we slide and tilt the probe, looking between the ribs. In the apical four-chamber view, one must be careful to avoid foreshortening. Currently, the image is foreshortened. The left ventricle appears shorter than it actually is because the probe is not positioned at the apex of the heart. After sliding towards the apex of the heart, we achieve a more accurate four-chamber view. In the apical four-chamber view, we see the left ventricle, the right ventricle, the mitral valve, the tricuspid valve, the left atrium, and the right atrium. we see a muscular band traversing the right ventricle, the so-called moderator band. This is a normal finding. The next view is the subcostal four-chamber view. Gently press the probe in the subxiphoid region with the index mark pointed towards the patient's left flank and the probe pointed generally towards the patient's left shoulder. Slide and tilt the probe until you visualize the heart. In this subcostal four-chamber view, we visualize the left liver lobe at the top, the right ventricle, the left ventricle. We see the mitral valve and the tricuspid valve, along with the left atrium and the right atrium. The echogenic line posterior to the left ventricle is the pericardium. Last comes the subcostal inferior vena cava view. Place the probe again in the subxiphoid position, this time with the index mark pointed towards the patient's head. Rotate and slide until you identify a long structure behind the left liver lobe. Tilt until you visualize the structure entering the right atrium. This way you can be sure that this is the IVC. If you tilt too far to the left, you can mistake this for the descending thoracic aorta, shown here behind the liver. So ensure that the structure you're visualizing is emptying into the right atrium. This view of the inferior vena cava shows the liver at the top of the screen, the inferior vena cava visible below it. You'll notice variation in the size of the inferior vena cava depending on the patient's respiratory cycle and also dependent on the venous pulsations.